Welcome. I'm Professor Ian Hickey, the Co-Director of Health and Policy at the Brain and Mind Centre of the University of Sydney. It's my great pleasure this evening to chair this particular presentation on right care, first-time 21st century approaches to engage young people with mood disorders. And I'm joined by staff who've been working with me at the Brain and Mind Centre over the last decade, and very importantly by Lara Espina-Polinos, one of our PhD students and now postdoctoral fellows who's back working in her home country in Colombia on an ongoing basis. And we'll be covering several critical aspects of the work in which we've been involved, excuse me, over the last few years. Now, just remember, we've got the chat function next to the live stream to make any comments and you want to make and interact with the attendees. If you're doing social media, please do use the hashtag IEPA 2021 virtual. If you're interested in a lot of the material behind this particular session, I'd recommend to you a Medical Journal of Australia supplement from October 2019 on this particular work, some as much of the principles that you'll hear outlined. Now, questions. And I'm told there's an incentive system for questions. Points are awarded, which apparently have some value in the virtual or real world future conferences to those who ask the most questions. So please do use the Q&A function throughout, and at 8:20 Eastern Standard Summer Time, or whatever the hell it is here in the eastern coast of Australia, we'll be joined by each of our presenters to actually have a further Q&A, although perhaps not by Lara, who has two small children and we think is asleep at 3 a.m. at the moment in Colombia. But the other presenters are all here live and interactive to discuss these particular issues with us. We've really been focused on young people with mood disorders, how they emerge, what are the stages of illness, particular issues that we've been addressing with Pat McGorry and others, their longitudinal course, and particularly their relationships with comorbidity, physical, alcohol and drug, other psychological disorders, and the progression of those particular disorders over time, their longitudinal course, their association also with risk, of course, in terms of suicidality, and very importantly, with functional outcomes. And for those who are really up to date and really interested, I direct you to this week's Medical Journal of Australia with an excellent article by Frank Iafino on the longitudinal course over 2 years of young people with these emerging, often complex anxiety and mood disorders. If you think impairment only happens to people with psychotic disorders, I've got news for you. It happens to people with emerging anxiety and depressive disorders, and often with complex phenotypes that represent very significant clinical challenges. And across the youth mental health world, we are part of that camp, which is fundamentally transdiagnostic or non-diagnostic, much more interested in the personalisation of care, in its tracking over time using measurement, on using technology and interaction actively with young people and their families to deliver best possible care. I often say as a clinician something that sounds rather harsh, which is I'm not that interested in people who get better or get better quickly with minimal intervention. I'm really interested in those who do not get better or those who deteriorate despite presenting for clinical care, and how through better personalisation, better assessment, better tracking over time, we might do a better job at getting not just reduction in psychological symptoms and reduction in risk due to suicide and self-harm, but reduction in comorbidity with other psychological disorders, with reduction in physical health problems, and very importantly, with improved functional outcomes. That's a lot of things to try to be doing with young people. That requires different kind of approaches to care. So we are very much promoting other models of care. I'm also, for those who don't know it, a fierce critic of our traditional primary, secondary specialist services, for those who are part of the old British Empire, those things we inherited from the old NHS, of a primary care system that acts as a gatekeeper to effective care, tends to keep people, particularly young people, away from specialist care, and tends to have a fail first or step care mechanism. You come along, and if that doesn't work and that doesn't work, eventually you might get to see somebody who could have helped in the first place. Hence the title of this particular symposium, Right Care, First Time. And the first speaker in the symposium is someone very close to me. In fact, she lives here with me in Sydney most of the time, although British by birth. And that's Associate Professor Elizabeth Scott from the Brain and Mind Centre and also from Notre Dame Medical School, who has really led our clinical program over the last 15 years. She does most of the clinical work, while I'll do a lot of the talking about the clinical work. She provides most of the care, leadership, and the education associated with that. So she's going to give the first presentation in this symposium on utilisation of technology-assisted assessment in a young adult psychiatric inpatient cohort. So over to the pre-recorded Elizabeth.
much for introduction, Ian. I'm going to be talking to you today about using technology to assist in multidimensional assessment and measurement-based care for young people with emerging major mood and psychotic disorders, both in community and outpatient settings, but also in a highly specialised inpatient youth mental health service. The aims of our work have been to deliver the best care the first time, to really be able to deliver enhanced assessment and highly personalised care at the first point of contact with the service by introducing a previously developed and digitally supported standardised care protocol and linked IT system, and to be able to test at scale the viability of a new user-driven care pathway. So using dynamic systems modelling, which I'm sure you'll hear about in this conference, and to use this pathway for young people with emerging major mental health disorders in clinical settings. And anybody who's worked in digital technologies, the implementation science involving those technologies on the ground, know that piloting these clinical service pathways can be extremely challenging, and clinicians are often very wary and fearful and skeptical about the application of these types of platforms in clinical practice as to whether they really can deliver and make clinicians' lives more easy and the patients' lives better in terms of driving better clinical outcomes. The key role in all of this is to drive earlier intervention in clinical practice, to really be able to provide the care that young people need. Clearly, we're never going to be able to meet this need unless we engage and invest in digital technologies. One big learning for mental health service reform, however, is that it's not just about technology. Just implementing, putting technology in our existing clinical services is not the answer. We've published extensively about this and about the development of a model of care which involves technology-assisted or technology-enabled care. It was published in the MJA in 2019, Right Care First Time. And essentially that involves a multidimensional framework. So when you ask young people what they want out of care, they tell us consistently that what they want is better social function. They want to be able to go to school, they want to be able to go to work, they want to be able to participate socially, they want to have good physical health, they want to be able to sleep well, they want to feel good about themselves. It is not necessarily about the level of symptoms that they have, it is actually about their capacity to function in the community. So in order to meet those needs, we need a multidimensional framework to our clinical care. We have engaged in how to implement clinical staging into practice, into service delivery, and how to include in that the pathophysiological pathways that underpin young people's disorders, the trajectories that they're on in their social environment and in the context of their biological development. So that is the personalised assessment component of care. The service delivery component of it includes real-time monitoring, be able to respond to young people's needs in real time across those multi-dimensional factors, and to be able to track those outcomes and to implement technology to be able to drive that type of care. Clearly, our traditional services really struggle to provide anything like the degree of monitoring or outcome tracking that digital technologies can provide. So the technology platform, digital platform designed for young people in mental health services to deliver this personalised and measurement-based care. So just to talk a little bit about the clinical staging, this was a book which is described in the book published by Pat McGorry and Ian Hickey about diagnostic characteristics, how that clinical staging model relates to the trajectories that young people are on. And we've described these three major trajectories: the anxious depressive trajectory, a circadian bipolar pathophysiological pathway, and a neurodevelopmental pathway, which we have hypothesized leads on to the development of more severe psychotic disorders, so that you can start to define and characterize young people by the stage of their illness that they're at, by which pathway they're on, and what are the key biological, neurobiological events that are occurring at that time that enables us to understand the underpinnings, the neurobiological underpinnings, in addition to the social environmental factors that are at play. That enables us to develop a complex model of illness, and this is not as complicated as it looks, that helps us to understand the degree of crossover of symptoms that young people have, the noise that you see in youth mental health clinics when you see people at early stages of illness, when what we are trying to do is define who are the young people that are going to go on to develop these more severe trajectories, illness trajectories. So who are going to go on to develop more severe psychotic illnesses, more anxious, more severe depression in the anxious depressive spectrum, or going on to develop bipolar disorder. And the patient groups that I'm going to talk about in terms of the inpatient groups clearly are the severe 1B end. They are really with emerging severe disorders of the psychotic disorders or bipolar disorder, or they're at stage 2. They've already reached full threshold for their disorders. And it allows us to also then, in this model, look at the additional factors associated with drug and alcohol use, how that overlaps with social and occupational function and neurocognitive functioning at each of these pathophysiological pathways and at each stage of illness. So our goal is care that is personalized, highly personalized, and with the idea that the assessment and the sequence of interventions and the services are tailored to the individual and their needs. So the service responds to the patient's needs rather than the patient having to fit into the service criteria to meet the threshold for the service and to fit into whatever the treatment services that are provided, the treatment interventions that are provided. That services should be patient-shaped, which I think is quite different, certainly from many of the services that I've worked in, where we still expect that patients will receive the interventions that we are good at providing. And that our care should be measurement-based, and that's the use of systematic and continued assessment of outcomes to guide clinical decision-making, i.e. our treatment interventions should be data-driven. And again, that is a very big difference from the systems that we currently run. So Ashley Tickell, who is one of our PhD students, published a protocol for implementation of a digital platform, of this digital platform, the InnerWell platform, in an inpatient mental health unit and in the private system in Australia, which is very much constrained by private health insurance and is very much based around a kind of group model of intervention around psychological therapy. So it really is not specifically tailored to individuals. And so the goal of this was to follow a large cohort, about 400 people, young people admitted to hospital for mental health care, to look at the determinants of their kind of clinical presentations, their physical health, their social, educational, and occupational outcomes, and to look to see how using a technology-enabled care, how that would impact on their outcomes, and to look and see what different variables such as metabolic, hormonal, cognitive, circadian, and other symptomatic data would be useful in driving decision-making in these patient cohorts. So the protocol for this multidimensional assessment and tracking involved baseline assessments when the young person was admitted to hospital, involved metabolic and hormonal assessments, neurocognitive screening, actigraphy, so looking at sleep-wake cycle, using acti-watches, and in addition to clinical assessment and a self-report questionnaire, which the young people did on an iPad. All of that information was then fed back to the clinical team within the first 2 weeks of the young person being in hospital. So the majority of it within the first 7 days, the circadian actigraphy within the first 14 days of being an inpatient in hospital, to see how then that would drive clinical decision making and how that would impact on the interventions that the young person received and their outcome. And then to follow up that group of young people over a 6 month, 12 month, and 24-month period with this repeated assessments. Like many things, COVID has interfered with the implementation of this trial. We hope that we will continue once we are out of lockdown in Australia, but we have been continuing this work in our community and our outpatient settings. What that allows you to then see is how different interventions then impact on different outcomes. So in addition to the clinical course, the symptoms that we're all always engaged in trying to improve, how much do interventions based around employment support and placement then impact on alcohol or substance misuse, or on physical health? How much do physical health interventions then impact on self-harm and suicidal thoughts and behaviours? How do they track with social and occupational function? So you can start to see how specific interventions start to have both direct and indirect effects on the outcomes of interest. So in order to put these platforms into clinical use, obviously the technology you choose is critical. And we have, I guess, we look a lot at technology as assisting clinical practice. Much of the technology that we have in place just makes it easier for us to do the things that we traditionally do in clinics. So I now can write e-scripts, electronic scripts. That is fantastic. But it actually doesn't change my model of care. It doesn't change, really substantially disrupt the type of care that I provide, or necessarily, or improve patient outcomes. What actually is required, if we're really going to go into more 21st century enabled care and innovative care, is the user journey that's supported by digital health information systems, where the user actually owns the data. It is the user that navigates the system using the platform. It is not the service that directs the patient. That is a substantially different and innovation in terms of clinical practice. So in terms of designing such systems, what do they look like? And why do we need them? Well, clearly for users, for young people in the community, we are not going to meet the demand for care. Our services currently can't meet the demands. We've seen escalations in presentations for depression and anxiety with suicidal thoughts and behaviours. Our clinical services are overwhelmed. We don't have anywhere near the early intervention capacity to intervene early enough to change the course of illness for many young people. Clearly, when you provide technology-enabled care, you can improve access, arguably improve quality. These systems for young people are associated with high levels of engagement, and really importantly with a sense of empowerment of being able to direct your own care, and also minimizing stigma. For the community and the family, it provides opportunities to engage directly with service providers. And again, some of the major complaints that we have from families are really not being involved in care. So this provides the opportunity to put information into the system, but also to receive information out and to be able to work in collaboratively with service providers. For the private or the public funder, there's clearly a demand to provide better services, and that requires investment, but also it has the capacity for accountability. Are the interventions and the services that you provide really driving the outcomes of interest, the outcomes that are really needed to reduce disability impairment in the longer term? For providers and clinicians, we hope that the use of real-time data to personalise and deliver care over time makes life easier and actually is rewarding in terms of driving better outcomes in terms of care. What we have built in terms of the Synergy platform now, the InnerWell platform, is an online system that was built with end users collaboratively, with the aim that they would be controlling their data, that is designed to interact with a multiple of other apps and online services that are out there, and that can take data in and output data, and can track young people across the multiple across multiple services and multiple environments. So it really can help to drive collaborative care. What the individual user journey looks like is shown here, where you get a dashboard of your overall health. So this provides a snapshot or a dashboard, shows you what your overall health, your mental health, your everyday function, what level of psychological distress, the level of suicidal behaviors, and a series of cards down here where a young person, in terms of inputting their data, can indicate their areas of major concern, and whether it's their sleep or significant depression, suicidal thoughts or behaviors. So it's very clear to clinicians what are the young person's major areas of concern and how they change then over time. In terms of implementation, digital platforms are one thing, actually putting them into clinical practice obviously is the major challenge. And we have done now a number of trials in the community looking at these technology-enabled person-centered mental health services to understand how to implement them into clinical services and to provide, whether we can work towards providing wraparound care for young people, and to see how well these platforms stack up both clinically, scientifically, analytically. How do they assist staged care, service delivery? How do they detect suicidal thoughts and behaviors and the escalations, the deteriorations that young people experience? How do services respond? Does that result in better, faster care that helps to reduce risk over time? And how can services use the data to improve their services at quality data, to make services more accountable and to assist services in the utilization of their resources more effectively. So what you see out of the database, what you can see out of the whole data set for a service, you can see the level of psychological distress that your client populations are presenting with. This is based on K10 data. You can see the rates of depression, anxiety, psychotic disorders. You can see how that breaks up in your patient populations. You can also see the level of social occupational function, comorbid drug and alcohol use, what their physical health characteristics are like, how many of them are maybe in the 1B category or going on to develop more severe disorders with more mania-like experiences or psychosis-like experiences. So you can start to track the clinical characteristics of your population. You can also do that with suicidal thoughts and behaviors to start to see what percentage of young people are presenting with more severe suicidal thoughts and behaviors or self-harm. Link young people up with the apps and the online services to provide real-time support for them through the platform, and see how clinicians respond to escalations of care and to the notifications of a deterioration in function, escalation of risk. When you ask people what they think of this is data from out of Headspace. Many see the benefit of using a platform like the InnerWell platform and believe that the platform is appropriate for clients in youth mental health services. The percentage of people who are willing to implement a particular platform, this was the InnerWell platform, is probably not as great. And this reflects the fact that technology in clinical practice has a number of barriers, and we are far from having a system which is perfect. What is, I guess, worrying is that only about half of clinical staff really believe that it was their role to engage young people in technologies in mental health care as part of their treatment, or that the youth mental health services had a culture which really encouraged the integration of technology. So again, we have a long way to go. What are some of the barriers? So at a service level, you can see this is from structured interviews and workshops conducted at the Brain and Mind Centre at the University of Sydney. You can see that there is clearly services identified that there is a need to meet gaps in services. There are issues around implementation. There are lots of negative issues around resourcing, around existing information and technologies, which are a barrier to new systems, and how we pay for care. At a health professional level, clearly health professionals see that things need to change, that the level of communication and efficiency, there are many advantages of technology-enabled care. And at a consumer level, the advantages outweigh any of the negative benefits in terms of access to care, in terms of wanting things to change, in terms of being able to utilize the platform in the way in which it was intended, and in terms of young people's clear digital literacy. So in conclusion, what is required are 20th century digital information systems, not simply apps. These systems have tremendous power to transform access and quality of service delivery. And this care is global in its reach. But as with all things, they need to be tailored to be delivered locally to meet the local needs of the community. In many cases, it is easier to develop new services, to develop greenfield sites, rather than to transform existing services where there is many barriers and potentially resistance to change. And we are not going to get anywhere unless we work in partnerships to actually establish better ways and better systems of doing things. I guess the overall kind of the environment is clear that Uberization is coming. We are going to have to use technologies in clinical practice. And if we don't change our ways, it is entirely possible that developing countries like South America, like countries which are highly digitally literate and have no limited existing infrastructures, will develop better systems of care, and in a kind of reverse colonialization will help us to reform and innovate the care that we provide. So thank you very much for your attention. I'd like to thank my wonderful team of mostly young people who work on these technologies, and the many young people and families who have worked in partnership to inform and assist us in the work that we do. Thank you very much.
Thank you, Elizabeth. It's a marvellous overview of the outline of our work, and many of those key slides are available in our Medical Journal of Australia supplement from 2019. If you want to see the details of some of those complex ideas in terms of multidimensional assessment and tracking and where technology fits into this youth model of care. Right at the end there, Elizabeth's warning, Uberization is coming. Technology is happening. The challenge for us in clinical services is how we adapt to that. And Liz finished up by saying, of course, it isn't just happening in developed countries, and some of the most exciting developments are in developing countries. And our second presentation tonight is from Dr. Lara Ospino-Polinos, who is a postdoctoral fellow of the Brain and Mind Centre. She trained as a child psychiatrist, originally in Colombia, then also with further family therapy training in Italy, in Milan. So she speaks Spanish, she speaks Italian, she speaks Portuguese, and she speaks English extremely well, better than me, many would say. And she has really gone back to Colombia, having done her PhD with us on the use of information technologies, to lead work in that country, in a developing country, where the demands are huge, but the potential to also use technology is also extremely large. So I'm really glad that we have a presentation tonight from Lara about the emerging use of technologies in middle and lower income countries. Over to Lara.
Good morning, everyone. Thank you so much for joining us in this session. My name is Laura Ospino-Polinos. I am an assistant professor at the University Javeriana here in Bogota, Colombia. I'm also an associate researcher at the Brain and Mind Center. And also I am the head of the subcommittee of telehealth and teleeducation of the Colombian Association of Psychiatrists, and an active member of the telemedicine and informatics section of the World Psychiatry Association. Before I start this presentation, I just want to say that I don't have any conflict of interest to declare for this presentation or for any of my research. Thank you so much for joining us. I would like also to thank my colleagues here in this symposia, and especially to Professor Yang Hickey. Thank you so much for having me and inviting me to present this to you today. So I am currently, right now I'm going to show you my full presentation. I'm going to talk to you about how we can develop health information technologies so we can transform mental health care, specifically in low and middle income countries. The term that I'm going to use right now is digital health, as digital health is an umbrella term that includes not only telemedicine or mHealth, eHealth, but also makes reference to big data and artificial intelligence. So what is the current situation of low and middle income countries now? So we all know about mental health burden, and I want to specifically draw your attention to these numbers. Low and middle income countries host 80% of the population worldwide and 90% of the young population. And just 20% of the resources are invested in these countries. That makes that these countries have a huge treatment gap. And when I'm saying treatment gap, I'm meaning that if I need help and I go and seek help, I actually get the help that I need. So in some countries, the treatment gap could be as high as 90%. The treatment gap in Colombia is 60%. And that makes specifically huge health inequities between high-income countries and low and middle-income countries. The Lancet Commission in 2019 have make a case of how ICT can enhance traditional services to make care more accessible. On the same line, the World Economic Forum has made also a statement of how we can adopt technologies in an ethical way so we can expand access of mental health. And they provide some initiatives and they provide some actions of how to regulate and make policy around this practice across the globe. So we know that ICTs in mental health have been effective at all levels. So starting from psychoeducation to making a diagnosis, providing treatment, monitoring some outcomes of interest, making digital phenotypings, increasing peer participation through social media, and of course, providing training and education via telemedicine. So with this in mind, with the evidence base, with the international foundations, resources, being vocal about how we can improve and implement technology, we also have the Sustainable Development Goals that show us in goal number 3, how we can increase mental health access, and Sustainable Development Goal 9, Internet affordable for all. This makes a specific case scenario for implementing ICTs in practice. So in line with this, and in line with what I have been telling you about health inequities, I have to tell you that low and middle income countries also face something that is called the digital health gap. So that means that not only we face treatment gaps, but also now we're facing a digital gap. That means that a lot of ICTs in health have been developed in high-income countries, but we are still very, very behind on the development and implementation of technologies into care. So this is just an example. In 2019, I supervised this thesis where we reviewed the number of mental health apps available in the stores. And we could find that apps in the Australian store, for example, and apps in English about mental health were around 2,500. But in Colombia and Spanish, there were just 350. So that makes and that illustrates this digital health gap that I'm talking to you. So now I'm making a call to action. The call to action is IIS, Innovate, Implement, and Sustain. When I'm talking about innovate, we have to assess the needs and the opportunities of the context and the cultures and the different settings. And then we have to understand if we have to create something from scratch or we can add something that has been proven effective elsewhere and adapt it to a new culture, context, and language. When we make this call, we then have to understand the risk of the ICT that we're talking about. If it's no risk or minimum risk, we could implement this very, very quickly, straight away, basically. And if we're talking something more than a minimum risk, we need more trials, more regulations. We perhaps need approvals and authorizations. And those are the cases that are going to take a little bit of time, but I'm not saying that we cannot do this. We should do this because we need, for example, diagnostic ICT tools or treatment tools that can help us as well, but we're going to take a little bit more of time on those. And then the other thing is that when we decide to create it, to adapt, and we decide to implement, we should think about the future, not just the needs on the moment, but the future, and try to see how this system or the ICT that we develop or we adapted, how it's integrated to the system or to other technologies, so we can make a case for the future and not something that we created is really fancy, really nice, but then it dies in a short time because no one is going to use it or it doesn't integrate well with the health system. So when I was telling you about creating or adapting, I just have to tell you that we have already published this methodology on how to adapt an ICT into different languages, cultures, and contexts. This is the book chapter QR, so you can take it a look and read how you can do this. This is just a methodology proposal. So basically what we want is to involve end users, people who are going to use this ICT in all the adaptation process, not just as consultants, but we want them to be really active on how this ICT needs to be adapted to different contexts. We held participatory design workshops, user testing sessions, knowledge translation, and everything over there. You can find it on that book chapter. But then the other thing that I was talking to you about is which are the technologies, the ICTs that we can implement straight away. So for example, and I'm going to show you examples in my hometown, we have adapted one support and counseling service for new dads, new parents that are transitioning to be a dad. So how we can implement and increase the bond with the newborn, improve the relationship with the mother, and provide also care to themselves, increase their well-being. So we do that through traditional SMS messages, texting, so we can improve this. We have already done this in cooperation with the University of Newcastle. We have already finished this feasibility trial. It is acceptable for Colombia, and that's we're really grateful that we provide this support through this very simple technology. Then the other thing that we could do very simple, it's surveys. So this is just an example of how online surveys could reach a lot of people in a very short time. So this was one survey that we did with the pandemic. We wanted to know how was mental health in young population in Bogota. In just 1 month, we got 850 responses to the survey, and thanks to that, we obtain a very good sample from all the different localities in Bogota, but also across all different socioeconomical status. So everyone responded this question. The lowest socioeconomical status have very good response rates. So actually that demythifies or breaks down the myth that most vulnerable populations don't have access to devices and internet. It's not like that. They have access and they are using it. So we should implement thinking this. And then the results of this survey show us that there's a huge mental health need of care here in Bogota, as people are struggling a lot. So 70% of the people who responded to this questionnaire had significant symptoms of depression, and 56% had significant symptoms of anxiety. So with that in mind, with the need, now we have to provide affordable strategies to reduce the psychological distress. And one of the tools that could be effective is psychoeducation. Psychoeducation is an area that has been proven effective since a long time, since mediated through the internet and new technologies. This is just an example of mental health repository that hosts that is the largest actually Spanish-speaking repository of mental health resources in the world. This is called Mental Punto de Apoyo. Mental Punto de Apoyo has information and multimedia resources for all the different audiences, from people with lived experience, children, adolescents, clinicians, carers, and say through the pandemic, we have increased this number of resources and e-tools, and we have customized it to the needs. So for example, mental health during the pandemic, we have created a mindfulness cycle for anxiety. It's totally free, it's online, how to deal with grief. And we have provided so far in 1 year, 72 multimedia e-tools. We have also started doing some podcasts that you can also visit in Spotify. And I was telling you that this content is tailored to different audiences. So for example, this one is a little animated story about a doglet that needs to wear a mask, and that is actually teaching our children how to, in the importance of wearing a mask and caring for themselves and for others. This is 1 year of this psychoeducational repository. We have had around 2,000 visits to this website, and that is showing us that people actually is accessing to this information. The other strategy and the other program that we have implemented, it's called Collective Minds. Collective Minds is a support and a support and emotional support program to help people during the pandemic. Thanks to a cooperation between the Faculty of Psychology, Medicine, Nursing, and Engineering, we developed a platform that provides care. So it connects the person who needs care with a counselor. In that case, the people who provides this counseling service or this emotional support service are students from the Faculty of Medicine and Nursing and Psychology. They are connected via online via this platform that developed the engineer faculty. So we provide for our populations, and this is totally free, active and empathetic listening, emotional first aid, crisis intervention, problem solving, and self-management. We provide from 1 to 4 or 6 sessions according to the need. And that's actually a first line intervention to help to reduce this mental health crisis that we're currently facing. So as I was telling you, this is free, totally free, totally online, but we're also, as the situation develops, starting to help another kind of population. So for example, health workers, people that are currently returning to workplaces. And very, very importantly, we have been supporting elderly populations that live in facilities, in nursing homes, that with the pandemic were very vulnerable, and they were very isolated and deprived of this social connection. So we provided support to them. And the really good thing is that we could also increase the digital knowledge, the digital literacy to an emotional digital online support program. So this is our website, our Instagram. So far, we have had around 2,500 support sessions to different populations around Colombia. We still need to go to the south, but we have also starting to do some support to populations that have been experiencing a lot of internal conflict now in post-conflict settings. And this is a picture of the elderly populations accessing to our service. So Collective Minds makes use of different online interventions that we know effective. So from psychoeducation to first line intervention, also teleeducation, because our students have been trained by an online course. Then the other technologies that we can implement through trialing are the ones that are moderate to high risk. So this is just an example of how we adapted using the methodology that I previously mentioned, how we adapted a mental health e-clinic from Australia, and then how we adapted it to a Spanish-speaking population, to a migrant population in Australia, and then how we took this to Colombia. Then I was telling you that the digital health term makes reference to also big data. So we have another project in cooperation with the University of Sydney, CSART, and the Swiss TPH, funded by the Botnar Foundation, where we want to systems modeling. We want to predict what are the best interventions that are going to decrease some of the mental health outcomes, the negative mental health outcomes of, for example, suicide, or decreased social participation or functioning. So which are these combinations that could provide the best results to these outcomes? And of course, we make here use of big data, but we also want to design a platform that collects granular data that at the end makes big data, so we can incorporate that to these models. So we created a platform that young people can use here in Bogota. So young people access through social media, then they get some tips and advice related to what they were looking for. Then they could monitor and track different mental health variables. And with that in mind, we can have a lot of information, granular information that then we could use in the systems modeling, or also a clinician or health professional with those variables that we have monitored can make and help young people to make better decisions in relation to their health. So we're also providing personalized care with this kind of platforms. Of course, nothing of this that I have told you have been possible without an international cooperation. So that's the reason why I'm here talking to you, because I still have a lot of connections with the team that I presented today. And we are creating strong alliances to take all this knowledge that has been created and implemented in high-income countries to our countries in for example, in Colombia. So this is just one picture. I don't have the most recent pictures because currently the pictures look like Zoom meetings with all the faces in little squares. So I would like to finally conclude that we all are part of bridging this digital health gap, that it's possible, that we can make it if we work together, if we integrate our systems, and we have to make smart decisions about creating from scratch or adapting something that has been already developed. I would like to thank you so much for your attention, and I hope to see you soon in the Q&A panel. This is my email and my Twitter account. So if you have any questions, please write me an email and I'll be happy to respond to you. Thank you so much.
Thank you. Thank you so much, Lara, from downtown Bogota. And if any of you have ever been to Colombia and Lara has the opportunity to take you to Cartagena or any of the other marvelous places, Bucaramanga, Medellin, the technology in Medellin is fabulous, you must accompany her there. It's very sad the World Psychiatric Association wasn't able to meet in Cartagena this year due to the COVID crisis. But Lara is a marvelous example of somebody who is taking 21st century technology and 21st century thinking to developing countries, back to her home country, and a marvelous example of clinical leadership in those areas and of innovation. Always great to work with Lara, and hopefully she will join us in the Q&A. And if people have questions, I encourage them again to record them, bring them to us, and at 8:20 Australian Eastern Summer Time, we'll be answering those questions. On to our next presentation by Dr. Jake Kraus, who is a PhD from the University of Sydney. He's working in our Brain and Mind Centre and our Youth and Mental Health and Technology teams, now postdoctoral fellow, being supported to work on particularly the development of complex mood disorders, particularly those that might have an underlying set of pathophysiological mechanisms related to disruption of your body clock. of your circadian system. And I'd really recommend to you Jake's reviews in Lancet Psychiatry and Neuroscience and Biobehavioral Reviews this year on those particular issues. And tonight he's going to present on the longitudinal analysis of the evolution of mood and psychotic syndromes in twins. And this really comes out of a longer-term partnership with my old friend, I don't mind him saying that, both of us are old, we're quite young, Professor Nick Martin at QIMR, who's assisted me over the last 30 years, in fact, to be involved in a longitudinal study of twins and their families in that area, and ongoing collaborations with Sarah Medlin and others at QIMR Berghofer as part of that critical issue, studying what happens in populations, which are genetically informative, alongside studying clinical populations. So Jake, welcome. Let's hear your presentation.
Hi everyone, thank you very much for tuning in. My name is Jacob Kraus. I'm a postdoc at the Brain and Mind Centre at the University of Sydney. And today I'll be talking about some of my team's research studying the evolution of mood and psychotic syndromes in young adults in Australia. So I'd like to start by paying my respects to the traditional owners of the lands on which the University of Sydney is located, the Gadigal people of the Eora Nation, and pay my respects to the knowledge embedded forever within the Aboriginal custodianship of country. And I have no declarations of interest to make today. So we know from quite a large body of epidemiological evidence that the greatest burden of mental disorders is in youth. So most mental disorders emerge when people are young, about 50% by the age of 15 and about 75% by the age of 25. And these illnesses in youth are associated with a massive burden of disability. And we know from longitudinal studies that many mental disorders among adults are extensions of disorders they had when they were young. So this evidence together suggests that our efforts to prevent and intervene in mental disorders may be best placed in youth. We also know from quite a large body of evidence that mental disorders are extremely heterogeneous, especially so among young people and in the early phases of illness. And there's a growing notion that studying pathways to various stages of mental disorders transdiagnostically, so from non-specific symptoms to subthreshold syndromes to full threshold syndromes, may highlight new areas for transdiagnostic prevention and early intervention. So I'll be talking about two studies on this theme today, looking at trajectories to subthreshold and full threshold syndromes in a community sample of adolescents and young adults in Australia. So this sample is a large genetically informative sample of twins and non-twin siblings, the Brisbane longitudinal twin study. These individuals were recruited from the community around Brisbane, Australia, around 1992, and they're a richly phenotyped sample. So there's measures of psychopathology, cognition, most have been genotyped. There are measures of substance use, neuroimaging. So it's a really rich sample to explore some of the evolution of mental disorders. And the repeated follow-up design allows for some of these causal factors to be inferred. So I'll be looking today at two follow-up waves of this sample, the 19 up wave, where participants are aged around 19, and again at 25 in the 25 up wave. So this first study is looking at progression to subthreshold syndromes from non-specific symptoms. So this study focuses on 664 participants from the Brisbane longitudinal twin study who completed assessments in both the 19 up and 25 up study waves. And these were young people who did not meet criteria for a full threshold mood or psychotic disorder at 19 up. And the assessments included measures of psychopathology, so a range of depressive symptoms, hypomanic symptoms, and psychotic-like symptoms, so a total of 23 different symptom items. A self-rated measure of social support using the Kessler Perceived Social Support Scale, measures of alcohol and substance use, including daily alcohol, daily tobacco, and weekly cannabis, and measures of impairment, including days in bed and days at a row in the past month. And the analytic approach used here is a type of probabilistic graphical model called dynamic Bayesian networks, which when used with panel data, as in here, we can use these to infer causal relationships operating over time. So dynamic Bayesian networks, or DBNs, are used in many fields, including microbiology, gene expression, traffic control, and they're increasingly popular in psychiatry, where we can start to use these methods to determine the causal structures that make up some of these syndromes and the different lifestyle factors that might be causally related to some of these syndromes. So there are many different possible networks that connect these different symptoms and related factors. So we use in this study a bootstrap design where we compute 1,000 bootstraps of possible relationships between these factors, and then derive a final consensus model, which reflects the model structure containing edges or relationships between variables that are observed in at least 50% of the estimation. So this is kind of our best guess consensus model. And there are two key questions we're seeking to answer. So in the first question, in the first model, we investigate how symptoms, impairment, substance use, and social support are interrelated over time among young people. And the second question in the second model was, can we identify precursors of subthreshold syndromes among young people? So I've got a diagram of the findings from the first model where we just focus on the within item edges. So these are relationships between the same item measured on two occasions, at the 19 up wave and then about 5 or 6 years later at the 25 up wave. And these lines indicate a potential causal relationship between the variable and itself over time. And the thickness of the line, which is also indicated by the number in this gray box, indicates our confidence in the stability of this item. So for tobacco at both time points, this relationship was observed in all 1,000 of these bootstrap estimations. So we can be very confident that this relationship is real. So just going down the list, this is a kind of a rank ordered list of the relationships. We see that there are 7 different symptoms, including 3 depressive symptoms, 3 hypomanic symptoms, and 1 psychotic-like symptom observed at 19 up, which increase the probability that they'll be observed again about 5 or 6 years later at the 25 up wave. And we see that all 3 of our substance use item and the social support item are all in this model as well. So their endorsement at 19 up is associated with an increased probability that they'll be endorsed again at 25 up. And in terms of the stability of these different edges, we see that the lowest score is for a psychotic-like item, which is feeling like you are experiencing thoughts which are not your own. And this is the lowest, this has the lowest stability, but there's a low base rate associated with this symptom, so that's not unexpected. And the stability for the remaining symptoms is quite high. So this is the same model, but now we're looking at the cross-item relationships. So these are relationships where one given symptom is observed at the 19 up wave, and that's associated with an increased probability of a different symptom or a different factor being observed at the 25 up wave. And these are observed across time, so we can consider these as a potential causal interaction over time. So again, there were 7 symptoms that were observed at 19 up that were associated with other symptoms or other factors being observed at 25 up. And notably, these were all depressive symptoms observed at 19 up. And in this model, the stability of the edges across these 1,000 bootstraps was lower than in the previous within item relationships, which indicates that, you know, we can be less confident that there is a causal relationship between these variables. But this isn't entirely unexpected. And in the second model, we were investigating the relationship between individual symptom items and progression to a subthreshold syndrome. So this is a constellation of multiple symptoms within this dimension. So we have a psychotic-like subthreshold syndrome, a hypomanic-like subthreshold syndrome, and a depressive-like subthreshold syndrome. And these findings should all be considered exploratory. So we ran this model at our 50% cutoff. So as long as an edge was observed in 50% of the bootstraps, then it made the cut. And unfortunately, in this model, none of the symptoms crossed this threshold. So in an exploratory model, we lowered or relaxed this constraint to 30%, which has been done in some other studies. but these findings should be interpreted with much more caution. So we see that feeling threatened by others at the 19 up wave is associated with an increased probability that this person would transition to a psychotic-like subthreshold syndrome at 25 up. We see that endorsing increased activity at 19 up is associated with an increased probability of having a hypermanic-like subthreshold syndrome at 25 up. And then we see two depressive symptoms, impaired sleep quality and anergia, which when endorsed at 19 up were associated with an increased probability of having a depressive-like subthreshold syndrome. So we probably need much larger samples to more reliably observe these relationships over time. So some interpretations of this first study. So these data-driven models give rise to some novel hypotheses that clinical and/or public health strategies which target a specific set of symptoms, including impaired sleep quality, impaired concentration, and increased activity, may reduce the likelihood of the persistence of these same symptoms, as well as the onset of other types of psychopathology. But as I indicated, the statistical confidence in some of these relationships was questionable for the second model, especially. So external studies are needed to establish whether these symptoms are reliably associated with persistence and emergence of psychopathology, both in clinical and community-based samples. So now moving on to the second study where we look at progression to full threshold syndromes. So this study focused on 1,815 participants from the 19 up wave. The mean age for this sample was 26. And about 1/3 of these participants met criteria for a full threshold mental disorder. And the assessments were similar to the previous study. So we looked at psychopathology, a total of 23 different symptom items. So these were depressive symptoms, hypomanic symptoms, and psychotic-like symptoms. But these symptoms were measured a little bit earlier than the previous study. So these were about age 15 to 19, so during adolescence. And we also measured family history of a major mental disorder in a first or a second degree relative. And this was an online measure based on the family history screen. And then we also conducted a diagnostic interview to diagnose a full threshold syndrome. So this was using the Composite International Diagnostic Interview, the CIDI. And we've coded this as the presence or absence of a major depressive, hypomanic, and/or psychotic syndrome. So we weren't looking at progression to these diagnoses separately, but in a transdiagnostic sense. So the presence of any one of these full threshold syndromes is the outcome. And in this study, we use a different form of machine learning. So a type of classification tree called a chi-square automatic interaction detector, or CHAID. So the CHAID analysis generates a bifurcating decision tree. I've got a little figure down the bottom which illustrates this. So this decision tree is composed of a root node or a decision node, which is that box in green. And this is the variable that has the strongest association with the outcome. So here we've got a full threshold mental disorder and also the lowest p-value. So then from this root node, the tree branches out and it grows iteratively into internal nodes and then terminal nodes. And the terminal nodes, which are indicated by these pink oval shaped objects, is the final node that carries the maximum information. So these CHAID analyses were conducted and cross-validated using a train and test approach. So where we split the sample into two different groups and then trained the analyses and then tested the analyses. And I just report the test set analyses. And the key question for this study is what are the pathways from early expressions of psychopathology around age 15 to 19 and related factors like family history to the emergence of a full threshold mood or psychotic disorder. So I'll be presenting two different models, and the difference between these models is that the first one does not include family history, whereas the second one does include family history. And the outcome variable is the presence of any full threshold CIDI diagnosis. So the root node, or the variable with the strongest association and the lowest p-value that's associated with the full threshold syndrome is depressed or sad mood. So this starts at the top of the decision tree. And then there are these forking paths that follow on from whether that symptom was present or not. And then it generates a a next most explanatory symptom and whether that one was present or not in this bifurcating way. And we've got the positive predictive values reported for each of these different symptoms in the gray box. So there's a PPV of 31 for depressed mood. And then we've got the final PPV for that branch of the tree in the pink oval. So kind of if we follow one branch of this tree from people that said yes to having depressed or sad mood, and then said yes to being overwhelmed, and then yes to having impaired concentration, the PPV for this model was 76. So we see that the utility in this type of analysis is that we can account for risk of transition to a full threshold syndrome, take into consideration these kind of bifurcating trees. And the overall AUC for this model was 74%. So that's still below the threshold that we might consider a useful kind of clinical prediction model. Now in this second model, we include family history, and we can see that the overall AUC for this model is just increased by 1%, so still below what we might expect for a useful clinical prediction tool. But this is using self-rated symptoms and self-rated family history alone. So family history is the variable selected by the algorithm as the root variable. So this is the variable that has the strongest association with the outcome of any full threshold syndrome and the lowest p-value. And then again, we have these bifurcating branches. And something that's noteworthy is that it's the same symptoms observed in this model as the previous one. So there's some reliability here. So following, I think, the best path, we have people that, so the best path in terms of PPV for people that indicate yes to having a positive family history are those that indicate yes for having impaired concentration and yes for feeling overwhelmed. And we have a PPV of 73.9. What's also noteworthy is that if we follow the tree to the left among people who do not have a family history and who do feel sad and depressed and who feel paranoid, we have a higher PPV. So one of the aspects of these models that have utility is that it accounts for both presence and absence of symptoms. So for certain individuals, not having a symptom may also be informative, in addition to some people having symptoms. So the interpretations for study 2. So machine learning analyses like CHADE used here have identified a constellation of symptoms associated with transdiagnostic caseness. So that's full threshold mood and or psychotic disorder. And there were 4 transdiagnostic symptoms observed. These include sadness, feeling overwhelmed, feeling paranoid, and impaired concentration. And these symptoms may improve our prediction of caseness compared to other early expressions of psychopathology. So it's notable that some symptoms that were key to the model, such as need for sleep and increased activity, might actually be more useful for prediction if they are not endorsed rather than if they are endorsed. And if this constellation of symptoms is reliably related to the onset of major syndromes transdiagnostically, this group of symptoms might represent a risk syndrome for more sophisticated screening procedures and more nuanced transdiagnostic preventative interventions. So now interpreting the findings across these 2 studies. So several symptom items were identified in both study 1 and study 2 as having some predictive utility, including paranoia and increased activity. And if replicated, some of these symptoms may represent components of dimensional risk syndromes for psychosis, hypomania, and depression, as they have utility for predicting progression to both a subthreshold and a full threshold syndrome, so they're dimensional. So some of these new analytic methods will be increasingly important for predicting these trajectories of illness in both clinical and population-based longitudinal samples, but a lot more work needs to be done here. And self-rated phenomenology, like we've used here, does have value for predicting these different trajectories. However, as always, significant variance remains unexplained, and new models should integrate other biological, psychological, and social factors such as genetic risk scores and actigraphy. So that's all I have for you today. Thank you for listening. Here are some references. And a big thanks to the contributors and co-presenters today. So Liz, Frank, Laura, and Ian, and a whole group of collaborators in Australia, the UK, the US, Paris, and Denmark. So thank you all very much for listening, and I think we'll take questions at the end.
Thank you, Jake, for that very interesting presentation. And I would really recommend that people look at the Queensland Brisbane longitudinal study of twins and a lot of its outcomes and these new analytical techniques being applied. Really interesting insights. Our last speaker in this particular symposium is another postdoctoral fellow from the Youth Mental Health and Technology team at the Brain and Mind Centre, Dr. Frank Iafino. And he will be an investigator talking on interrogating the complexity and dynamics of youth mental health among a cohort with emerging mental disorders. Frank really leads a really important part of our work in terms of using agent-based models, something I'm trying to understand myself at my advancing age with some difficulty, as to how you can actually use new modeling techniques to better understand the trajectories of people through the development of complex syndromes. Again, another area where the development of new tools in association with appropriate databases may lead to particular insights for better understanding clinical care, and a lot of the Frank's tied up with the better design of health services, such an important issue for those working with early forms of major mental disorders, and including those working with major forms of mood disorders. So Frank, glad to hear your presentation. Remind people we have the Q&A live at the end of this particular presentation.
Hi everyone, my name is Frank Iafino and I'm a postdoctoral research fellow at the Brain and Mind Centre at the University of Sydney. Today I'll be presenting our work, which has been supported by a Medical Research Future Fund grant focused on explainable machine learning to improve youth mental health care. This specific study looks at the dynamics between youth mental health outcomes among a cohort of young people presenting to youth mental health services. I'd like to thank my team for all their work on these analyses, namely Matthew Varadel and Roman Marchant, for their technical and mathematical contributions. Now, we know that the prevalence of mental disorders among young people prior to the age of 25 is high, and that the impact these disorders have over a lifetime are significant, with the peak burden of illness occurring during the adolescence and young adulthood period, even if these disorders are sub-threshold or have remitted. So we are very interested in how to intervene early and effectively to prevent or reduce the impact these disorders have as people move into adulthood. And so over the past decade or so, our team has established a cohort of young people between the ages of 12 and 30, presenting for youth mental health care with a mix of sub-threshold and full threshold anxiety and psychotic disorders. You can see that the most common diagnoses in this group are depression and anxiety, followed by bipolar disorder, but also there's also a large proportion of approximately 40% who have some type of at-risk mental state phenomenon, which speaks to the complexity and heterogeneity of this cohort. Recently, we've established a longitudinal study that aimed to determine the long-term outcomes for this cohort. So we did this by examining and collecting data from the clinical notes for about 2,700 people, whereby about 30 variables covering illness type, clinical features, functioning, suicidality, and so on were tracked from a baseline up to about 5 years. And that this depended on how long someone was engaged with the service. And the distribution presented there is for social and occupational functioning, demonstrating that most people, about 2/3, present with clinically impaired levels of functioning. Now, much of the work with this cohort and other subsets of it have established how the needs of young people span multiple dimensions. Youth mental health outcomes are diverse and extend beyond specific illness syndromes to include impacts on functioning and alcohol and substance misuse and physical health. So for instance, we know that about 1/4 are disengaged from work or education, or that at least 1/3 have thoughts about suicide. Smoking rates are about 2 times higher than the general population, while drug and alcohol use is 2 to 3 times higher. Such outcomes complicate treatment and they contribute to the negative long-term impacts of these disorders. So for instance, previous work with this cohort published in General Psychiatry by our team demonstrated that young people at stage 1A, so earlier phases of illness, have a lower risk of progression to full threshold disorders compared to those at stage 1B. However, a significant subgroup of this stage 1A group was characterized by more complex clinical presentations, such as having at-risk mental states, poorer functioning, and self-harm, which increased their risk of early transition to stage 1B syndromes. And these at-risk mental states and other indicators of early onset illness, such as previous medication use or a childhood onset disorder, also have some capacity to predict transitions from stage 1B to stage 2+, which is a full threshold disorder. Furthermore, recent work of ours published by the Medical Journal of Australia showed how most young people, about 65%, had poor functional trajectories, since they were either characterized as deteriorating and volatile or with persistent impairment. Lower rates of comorbidity, an earlier onset of mental illness, and social disengagement, or lower rates of social disengagement, was associated with stable, good functioning over a 2-year period. While self-harm and suicidality, physical comorbidities, substance misuse, and social disengagement were all associated with poorer outcome trajectories. So, altogether, this work indicates that most young people require more comprehensive and multidisciplinary approaches because of substantial comorbidity and complexity, and ambiguous or attenuated symptomatology. But efforts to intervene among young people with emerging mood and psychotic disorders are challenging due to the heterogeneous pattern of illness and diverse needs that young people present with. So while we've identified variables associated with illness progression and functional outcomes, much less is known about the causal relationship between these variables, which could be used to inform the target and timing of interventions. Prediction is an essential part of clinical decision making, yet its utility really depends on disentangling causation to build theory about what is driving specific outcomes so we can understand how to intervene effectively. If we wish to infer the causal relationship between factors, so for example, does substance misuse lead to youth disengagement, then traditional machine learning approaches can be dangerously misleading for 2 reasons. The first is that it is possible to construct many models, each consisting of entirely different factors, which have the same predictive performance. And this leaves decision makers unclear about which interventions may impact behavior versus those that are simply correlated with an outcome. And second, traditional machine learning methods typically have no uncertainty attached to them and give a false sense of security. If prediction is all that we require, then the traditional approaches, such as deep learning and others approaches, may be able to provide fast and accurate predictions and be quite powerful tools. However, for the safe and effective use of these approaches in healthcare, a greater understanding of the causal relationships which give rise to specific predictions and the uncertainty around them are needed to guide more informed clinical decisions. So, the aim of this study was to identify the causal relationship between illness syndromes, social and occupational functioning, self-harm and suicidality, alcohol and substance misuse, and physical health among a cohort of young people with emerging mental disorders. While the total cohort included almost 3,000 people with a total of 9,500 follow-up time points over 8 years, for this work we focused on a subset of 2,049 individuals who had at least 2 consecutive follow-up time points because we were interested in inferring the proximal influence variables at one time point had over outcomes at another time point, at the next time point, sorry. So this means that we are examining the dynamics between time point 1 and time point 2, or time point 4 and time point 5, whatever was available for particular individuals. So first, a basic correlation analysis reveals several important relationships. So variables at time, so time 1, which is just represented as t, are correlated with the same variable at time t+1. Functioning is negatively correlated with a wide range of variables at t+1. Alcohol and substance use variables are highly correlated with each other over time. which is the same for diagnostic variables, which have strong positive and negative correlations with each other over time. And this highlights key relationships that we would expect to see, but it doesn't provide any information about the causal direction or dependencies between these variables. The probabilistic relationship between a set of variables can be graphically represented by a set of nodes or variables, which are A, B, C, or D, and edges, which are the relationships between these variables, such as A, B, A to C, B, C, C, D, and so on. And pairwise Markov random fields, or PMRFs, are graphical models which can be used to show the relationships between these nodes. And these types of models are becoming quite popular in the study of mental health. However, they have limited inferential power given that they do not represent the underlying causal pathways. And this is illustrated by Ryan et al. In the figure here, whereby the same network can be derived using a PMRF, could be explained by multiple DAGs, or directed acyclic graphs, each with major differences in structure and inference. So, for causal inference, we use dynamic Bayesian networks, specifically probabilistic models represented by directed acyclic graphs, or DAGs, to learn the causal pathways that could explain the dependencies between variables. And the variables included in this analysis are covered in that table and cover the range of domains I've mentioned already. And so what we wanted to do was to learn the structure of these nodes and edges given the data that we have available. To do this, we used an MCMC sampling scheme which returned a sample of graphs rather than a single graph. Single graphs may be overconfident representations of the knowledge they learned from the data. So for these analyses, we used partition MCMC, which was implemented using BiDAG in R. And partition MCMC does the following. It first groups nodes into partitions determined by a hierarchy. It then randomly proposes changes to this by either splitting or joining partitions, as represented in that middle figure, or by moving nodes between partitions, like in the bottom figure. And then it samples the edges for each graph based on their Bayesian score. And we ran this partition MCMC several times, about 500,000 times, using random start points from which we returned approximately 10,000 posterior samples that we used to study the posterior probability distribution of graph structures from this data. Now, based on the distribution of these graphs, we return the following summary graph structure. The graph here shows variables at t at the top and those same variables at t plus 1 at the bottom. And the lines between these nodes represent edges whereby there was a directed relationship between two variables with a posterior probability of at least 0.3. The grayscale of the lines is proportional to the probability of that edge occurring across the distribution of graphs. And so we identified some critical dependencies over time among these outcomes. The first being, we can see that social and occupational functioning at T has a direct causal relationship with both self-harm and suicide ideation at T plus 1. And this relationship was identified in at least 80% of the posterior samples, which can be seen in the figure on the right. The second is that mania-like experiences at T has causal relationships with circadian disturbances, depression, and bipolar at T plus 1. The third is that self-harm at T has a causal relationship with mania-like experiences at T plus 1. And finally, we also see many dependencies which validate the graph distribution, such as suicide ideation and suicide leading to suicide attempts at T plus 1, or psychosis-like experiences at T leading to psychosis at T plus 1. We also ran the algorithm considering concurrent relationships. So that is, relationships at T plus 1 are dependent on both T and T plus 1 variables. And when we do this, we see a similar story, yet with a little more detail about some of the cascading pathways and dependencies between these variables. So you can see a central cascade from mania-like experiences and self-harm at T, influencing mania-like experiences at T+1, which itself has a cascading impact on circadian disruption, to social functioning, to suicide ideation, and to finally suicide attempts. This suggests that key progressions and the emergence of outcomes may be dependent on manic fatigue or circadian disturbance type illnesses. The graphs here demonstrate how we can start to understand the complexity and dynamics between various youth mental health outcomes over time, which may shed light on potential intervention targets. Now, for example, social and occupational functioning appears to be an important intervention target with potential effects across domains. So not only affecting functioning itself, but also suicide ideation and self-harm, which may have cascading impacts on some suicide attempts as well. Mania-like experiences and circadian disturbances, and to some lesser degree physical illnesses, appear to also be critical upstream targets for interventions which may have cascading impacts across multiple domains, with impacts on functioning, suicidality, and psychotic-like experiences. And finally, mania-like experiences themselves were to a degree dependent on self-harm, and this may be a potential novel intervention target which would need further exploration. In terms of next steps, the inferred DAGs here tell us about the dependencies between variables, but we don't know much about the magnitude or size of the relationship yet. And so current work we're doing is looking at developing edge parameter estimation so that we can look at these types of relationships and infer what these relationships may be, which may help us with the prediction models that we're developing at the moment. Also, we're really interested in exploring potential differential causal structures for subgroups of young people. So are there different causal structures for males and females? Do these structures differ by stage of illness? So are those in the earlier phases of illness have quite a different structure compared to those in later phases of illness? These will all be quite interesting avenues for further research to shed light on how to personalize these types of results further. So the huge individual variability in presentations makes it difficult to determine the target and sequence of interventions. Causality is of major interest in mental health research and practice because it facilitates our understanding of emergence of disorders and outcomes over time, and it helps us identify more effective treatments. Most studies to date in the area of network analysis and such related approaches have examined a lot of cross-sectional data, whereas longitudinal data is required to infer causality. And this is a major strength of this study, which has identified probable causal pathways, which would obviously need to be the subject of further analysis and replication. But this work provides valuable causal insights derived from quite a large or relatively large longitudinal sample of about or over 2,000 young people, and provides us with preliminary evidence for some causal dependencies in youth mental health outcomes, which could inform personalised care that promotes targeted interventions and secondary prevention. Thank you so much to my team for all their work on this, on these analyses, and thank you for listening.
Thank you very much, Frank, for that fascinating presentation. Again, using new techniques to look at not just associations, but potential causal pathways. Now, we do have a number of questions and we'll try and answer them directly, the ones that have come through on the platform. And we've got about 15 minutes now for the question and answer session. So if you have more questions from any of the talks, particularly we now have live online, Elizabeth Scott sitting next to me, Frank Iafino and Jacob Kraus. We don't have Lara, as it is 4 a.m. in Bogota in Colombia, and she has 2 small children, but Elizabeth's agreed to answer some of the questions, and we'll go right to the questions that came directly from the presentation. So firstly, Elizabeth, you can answer the question that was directed to Lara. Can you talk more about how to engage, educate, support individuals who have a resistance to digital platforms or other technologies? I'm specifically thinking about parents of young people who may not support or understand the young person's desire to engage in digital health, social platforms, etc. The question's from Alison Paul.
And a very good question, and something that kind of vexes us a lot in clinical practice, although I have to say a lot of the time we find it's the clinicians who are more resistant to digital technologies than actual...
I don't think it's the parents.
No, no, often that is true. That is true. So the general principles have really been about education. And for the young people, digital technologies are often part of their lives. So it's relatively easy to, as long as they understand what the purpose of the platforms are, to engage them. One of the critical things are, if you're engaging young people to put their data into a platform, clinicians have to be interested in the data they put in and to use it on an active and regular basis in clinical practice. If the data goes in and nothing happens, then young people quickly become disinterested. They don't see the relevance of it. So one is about educating young people and clinicians to actually utilize the data, how to utilize it as effectively as possible, what the purpose of it is, what the impact of it will be, and to use it in a collaborative partnership with a young person to plan their care, to recognize their priorities, to understand if they're meeting their goals, and to regularly review that, and within the framework of clinical practice.
So just on the parents and carers issue and the work we did in Project Synergy, developing these platforms, and this relates to my own previous work at the National Mental Health Commission, the biggest source of complaints we had about many services was the lack of engagement of parents and carers in the care of young people in particular. And in fact, using these platforms together allowed parents and carers to put information into systems and, with the young person's permission in a collaborative way, to get information out from the clinicians on an ongoing basis. So I think, as Elizabeth just highlighted, one of the biggest resistance in all of this is with clinicians. Just another thing to do, doesn't really fit in. Most of what they experience with technology doesn't make their life easier. It just makes another thing to do, as distinct from these systems, which allow constant interaction. And we would actually argue more empowered partnerships with young people, but also with their parents and carers, and also with other things like schools, other providers in the Australian setting, things like the National Disability Insurance Scheme, and others who can make use of the information and really supports multidisciplinary and team-based care on an ongoing basis. I think there are three questions now for Jake out of your presentation, Jake. Go to the first one from Roger Gurr, which also relates to a question that Roger has for Frank as well. The symptoms found to be significant also correlate with the symptoms of developmental trauma. And as trauma has a dose-response relationship with the severity of major disorders, have you tried to control for developmental trauma in the twin studies?
Yeah, that's a really important question, Roger. And you're right, we know a lot from epidemiology that adverse childhood experiences are a major risk factor for mental disorders as well as suicidality and other negative outcomes. These factors are measured in the twins, so we have questions about death of family members and close contacts, early life relationships with family that are negative relationships, as well as exposure to significant life events. But we didn't use these in the models for either study I've presented today. But it's a definite area of interest. Ian's been around a little bit longer with the twins than I have, so I don't know, Ian, if it's been looked at in the past.
Yes, and I think the work you're doing currently, Jake, where we try and look at the relationships between genetic risk and environmental risk, including developmental risk and environmental risks at different ages, tries to look at the relationship between those things. One of the great things about the twin study is you have data about the genotype, but you also have a lot of data about environmental exposures at different ages on an ongoing basis. So I'd simply caution against the explanation that one thing explains everything. Certainly the causal relationships and the relationships between various genotypes and various environmental exposures, including developmental trauma, may have complex longer-term relationships with the symptom sets that you see. So in the ongoing work about causality, the great advantage of the twin studies is that capacity to actually look at the relationships between genotypes and environmental exposures. So I would simply caution against any one explanatory model that says genes alone account for the symptoms, or environments alone, including developmental trauma, accounts alone for what actually happens. What we've mainly seen in most of these models continuously is complex relationships, and complex relationships at different ages in relation to different age-dependent phenotypes as well. It's complicated and doesn't lend itself to easy models. And I think that's what, of course, the beauty of the area that we work in is it ain't simple, but also some of the challenges in that area, that some of these relationships are actually quite complex. But these longitudinal type studies with an emphasis on causal relationships, opportunities for intervention, as well as obviously for prevention, but obviously for understanding some of the complexity of those developmental pathways is also incredibly relevant. That also relates to Roger's other question. We may as well deal with this concurrently, Frank, which is the influence of brain dysregulation from developmental trauma is missing from the data, but could be added as this is historical data that can be collated later. Do you want to comment? I mean, in a similar way, I think, Frank, we are looking for, and in fact, the Brisbane longitudinal twin study has collected a great deal of data on brain imaging in these particular areas as well as another aspect of its particular areas. So I think the answer to that question as well in the causal pathways and the Bayesian analysis is you can do this. But you want to add to that, Frank, about the incorporation of other neurobiological data within those Bayesian pathways?
Yeah, absolutely. It's definitely something we're considering because we are fortunate that for at least a subset of the sample that was involved in our study, we do have neurocognitive data as well. So that would be quite interesting as a further analysis to look at, if there are measures of dysregulation or cognitive inflexibility and other types of measures to look at whether they have causal influence on outcomes over time, which is what we would expect in terms of the pathophysiology of many of these disorders. But in terms of other types of trauma, there was an exclusion criteria with some groups in terms of if they had other types of trauma during childhood, for example. I think in terms of brain injuries and things like that were excluded from this particular sample. But in terms of the other types of developmental trauma, it would be interesting and important to look at in these future analyses.
In a similar vein, a question just added by Anna Lee asks, Zach, how can you control or integrate in the clinical variables neurodevelopmental disorders such as ADHD, which have high comorbidity with all the variables identified? You want to leap into that one, Jake? Because again, Sarah Medlin, who leads this work at QIMR, has an intense interest in what are the childhood phenotypes and developmental aspects, particularly ADHD, that might be precursors to the symptom sets. But do you want to comment, Jake?
Yeah, it's a really interesting question, Anna. And a great strength of this project is that the assessments began around age 12, and there are a couple of follow-up assessments which I didn't touch on today. So we do have a real opportunity to study some of the developmental pathway models that kind of portend some of these major mood syndromes in early adulthood. We think a lot of these things do have roots in childhood, like some of these ADHD phenotypes potentially leading to or predicting things like bipolar disorder. So it is an area of interest for us for sure, and we're looking into this soon. And it's a genetically informative sample, so we can partial out some of these genetic effects as well as environmental effects and looking at these things. But yeah, it's very complicated, but important questions.
So classically, what is done in the twin models is to look for what genetic factors might be influencing a number of phenotypes. So you may have some genetic factor that influences an ADHD phenotype in childhood, but is also exerting an influence on a neurodevelopmental disorder or a related phenotype in adults. So when you see the longitudinal association between ADHD in children and an adolescent phenotype, it doesn't mean that one caused the other. They could, of course, both be due to the same actually underlying genetic factor, which is influencing the different presentations of those phenotypes at different ages. And that's the kind of thing that is classically done in many of the twin models to see what common genetic factors underpin a range of phenotypes at different ages. Similarly, what common environmental factors like developmental trauma or other factors may underpin a range of different phenotypes. So the great advantage of these twin models is the capacity to look at these things, what are explained by common variables, as distinct from what actually may be causal between one factor, a neurodevelopmental factor, and the development of another phenotype at a later time point. Much of that work is ongoing. Sorry, Frank.
I might just add in, because I think Anna was asking in reference to the second study as well. And I think to add to your point about the phenotype expression, I think, because the study was looking at the sort of proximal influences between like T and T+1, as Ian sort of alluded to, some of the earlier phenotypes may have shifted and so may not be as prominent as of an influence in terms of its phenotypic expression on what might be driving functional outcomes or suicidality or other types of syndromes in adolescence and young adulthood. But the neurodevelopmental disorders is something we are also, actually, I've looked at it today, including into the dynamic Bayesian networks as well. So we're considering for it and considering it as a control in the models.
Just additional comment, I think I might have shared this story with Anna previously. In our cohorts, we do include kids with neurodevelopmental disorders who've also developed mood disorders and anxiety disorders, and at times, by some American colleagues, have been greatly criticised for that. But kids with neurodevelopmental disorders are at increased risk of having anxiety, depression, psychotic disorders as teenagers on an ongoing basis. So it's a really important issue to continue to study. And of course, with increasing emphasis on ADHD in both adolescence and then in adulthood, the position of those issues and trying to treat the cognitive dysfunction and the social impairment that is so prominent in your studies, Frank, about impairment actually predicting the onset of self-harm and predicting the onset of other phenotypes, dealing with cognitive difficulties continuously, where they arose, what is their nature, and what might be the appropriate interventions, is a really important issue. So one of the advantages of our large clinical study is that we always have included those kids and not excluded them because they had a prior childhood diagnosis of ADHD or had some other neurodevelopmental disorder, for example, being on the autism spectrum or having some other learning difficulty. As Jake said, in the twin studies, there have been some exclusion of kids that have actually brain injury, in particular as head injuries, etc., from the MRI studies on an ongoing basis. So back to the other questions. Back to Jake. Question from Michael Mora. I'd be curious to see the presence or absence of a close relationship with a trusted adult in the youth's life as a variable with this study. There have been large-scale studies that found this factor to be highly correlated with youth well-being. Did you look at the quality of youth relationships with trusted adults in the study?
Yeah, that's a great question. So we didn't look at it in the second study. In the first one, where we were looking at progression to subthreshold syndromes and kind of the symptom item level associations across time, we did include just a simple measure of, we called it a social confidant. So it was a measure from the Kessler perceived social support scale that asked whether the young people had someone in their life with whom they had a close relationship and they could share their private feelings. And it was a simple dichotomous yes, no, and it didn't specify whether the relationship was with an adult or a mentor type figure. So about 10% of the sample did indicate that they did not have that kind of relationship, and that was associated with a range of symptoms of follow-up. So even though it was quite a crude measure that we relied on, or a simple measure, it did have some predictive utility. So it's a limitation of the study that we didn't have a more in-depth measure, but it's an important question.
Well, I think actually the finding's even more important, Jake, and that's the one about actually having these things currently having big effects. In other words, we've been associated with the twin studies over a long period of time, having other intimate relationships positive that are of a positive nature. Things in my own doctoral thesis we never measure in terms of the intimate bond measure, which is included in the twin studies over in the adult twin studies over time, does have strong protective factors. In the last 50 seconds, apologies you haven't mentioned this, but you haven't mentioned it, Jake. Were there any significant differences between identical and non-identical twins in terms of outcomes, particularly for full threshold disorders?
Yeah, another really good question. So for these types of studies, there's always a balance we have to meet with statistical power, trying to get as many people into the analyses as we can and looking at differences in zygosity. So in both of these studies, we just adjusted for twin status rather than kind of stratifying the analyses. So we opted for more power to try and find these associations. So we didn't look at differences between identical and non-identical twins.
Yes, but your part of the answer is zygosity is controlled for. So if zygosity is having a big effect, if you're only seeing it within one, then zygosity would emerge as actually changing the nature of the particular factor. So the fact that zygosity does not emerge as a big confounding factor suggests
means we can be safe.
It's happening. These associations are happening in both identical and non-identical twins. In other aspects of the twin studies, when we're looking for heritability of certain kinds of factors, when you see they're twice as common in MZ twins than DZ twins, identical versus non-identical, then this suggests, of course, strong genetic transmission of that particular set of characteristics. These longitudinal studies, however, as I say, are controlling for it rather than looking for those associations.
I would say in the twin studies in general, you do see patterns of zygosity that you would expect for psychotic disorders having greater heritability as distinct from the non-psychotic disorders. And as you move down the tree, there you do see degrees of heritability, but they're much lower for anxiety and depressive disorders than they are for psychotic disorders or for bipolar disorder. So the twin samples sort of replicate the more general genetic features associated with common psychiatric disorders. Now, it's 8:40 exactly. The timing is perfect. So I thank the presenters that we've had, Liz, Lara, Frank, and Jake. And I thank the audience in particular for your attendance. And I hope that the rest of the IEPA conference proceeds in the virtual way. And as I say, if you want to see more of our work, go to the Medical Journal of Australia, particularly for the models, more of the work around technology to follow up Project Synergy. But thank you for your interest in our real concern about delivering right care first time to young people with these emerging major mood disorders. Thank you.